So, good evening, all. On behalf of Alchem Laboratories Limited, I, Dr. Vijaya Gunjal, Senior Medical Advisor, welcome you all for this unique metaphysical conclave on vitamin D, called as D Conclave. We will be joined by clinicians at 4 locations across India: Delhi, Kolkata, Bangalore, and Pune, along with thousands of doctors watching this program online. Today's topic is optimizing vitamin D management in India, a clinical perspective. I am honored to welcome our esteemed moderators, speakers, and panelists. So, it is our privilege to have Dr. Mangesh Tivaskar as the moderator for today's session. Dr. Tivaskar is a distinguished consultant physician and diabetologist at Shilpa Medical Research Center, Mumbai. He is the editor-in-chief of JAPI, former general secretary of the National API, and serves on the editorial board of several renowned journals. A gold medalist in medicine, Dr. Tivaskar has over 150 peer-reviewed publications to his name and has been honored with the prestigious Professor Laonil Ohopi Fellowship from London. He also serves an MRCP examiner for the famous Royal College of Physicians, UK, and brings unmatched clinical and academic expertise to this discussion. Thank you, sir, for accepting our invitation and giving us your prestigious time. So, without further delay, I request Dr. Tivaskar, sir, to steer today's deconclave by welcoming our speakers, panelists, and setting up the agenda. Over to you, sir.
Wow. Good evening, everybody, and good morning to Professor Holik from India. I know, thank you very much. I'm looking excited, right? But I do have a right to get excited because I'm there with somebody who is a pioneer in what we know about vitamin D. Friends, today is a very special day, not because I am with Professor Holik or Professor Bansi, but also because we are going to talk to you about one such so-called vitamin. I may not be right in saying it as vitamin. We all know it is a sterol, or it's a sort of an hormone. But this program is all partnership with IJCP, Alchem, and of course, Association of Physicians of India. Friends, to brief you about Association of Physicians of India, I am truly honored to represent Association of Physicians of India, a legacy of leadership in medicine. Founded in 1944 by 8 brilliant brains in Chennai, currently Association of Physicians of India stands as country's one of the most professional, prestigious medicine and the physicians body, having almost membership of more than 25,000. Over the decades, API has grown into the most elite academic organization, and events like this makes all of us, including all the APIans, very proud of being a most academic celebrated body of physicians in the country. I have a privilege of introducing two giants today. First, let's talk about Dr. Michael Holik. This is my third opportunity to share dais with him, and I'm truly privileged. What I know of Professor Holik is something where I can keep on speaking for another half an hour. A guy who has got H index of 174 and has more than 175,000 citations for the work, the research that he has published in various aspects, not only in the vitamin D sector, but osteoporosis, osteomalacia, stress fractures, hypermobility syndromes, Ehlers-Danlos syndrome, osteogenesis imperfecta, and the list can go on. Apart from being professor at Boston, he is also a chair of NASA's Human Health Countermeasures Element. How many of you know that he was responsible for finding out that vitamin D actually exists in a circulating form in the form of 25-hydroxyvitamin D3? You all are aware about the work which has been done by Elmer McCollum, who gets the credit of inventing vitamin D. Then comes the work of genius, a super genius, Adolf Windaus, who worked on sterols, including vitamin D3, and also has been awarded Nobel Prize for this in 1928. But then, work of Professor Hollick is no lesser than these noble giants. The importance of vitamin D has been quoted by New York Times, Forbes, Newsweek, Men's Health, Scientific American. Now, if you know about Scientific American, this is the platform where most celebrated researchers, scientists, Nobel laureates are talked about, including Time magazine. And of course, we do have got Professor Dr. Banshi Sabu. Banshi sir, he's been one of the gentle geniuses, a colleague, a friend, currently a Southeast Asia IDF chair, past president of Research Society of Diabetes, Studies of Diabetes in India, and of course the Obesity Organization. He has been editor-in-chief of RSSDI textbook of diabetes. And who doesn't know Banshi Sabu? In India, I fondly say that if you have to write down a letter to Banshi Sabu, just write down Dr. Banshi Sabu, India, and the letter will reach to him. This is Banshi Sabu. And of course, I do have got my fellow panelists, Vijaya. There is also Mumbai Center, those who are going to join. So we have Dr. Vaishali Deshmukh. She is Associate Professor of Endocrinology, Sassoon Hospital, consultant endocrinologist at Dinanath Mangeshkar Hospital, and she owns her clinic. And of course, who doesn't know Dr. Vaishali ma'am? Wonderful researcher, a key opinion leader, and one of the most important celebrated endocrinologists who talks about the connection of mind, body, and medicine. She has got a H index of 67, participated in so many clinical trials, phase 1, phase 2, phase 3. And of course, her interests are naturally the behavioral neuroendocrinology and women in endocrinology. Then we have Professor Dr. L. Srinivas Murthy. Srini is from Bangalore, a very close friend, consultant at Fortis Hospital and Apollo Hospitals in Bangalore, Vice President, National RSSDI. But a wonderful thing about Srini, Professor Hollick, I would like to tell you, is this that any new drug molecule, especially in diabetes, if it has to get approval in India from DCGI, it has to pass through Dr. Srinivas Murthy's Clinical Research Center. He owns a Clinical Research Excellence Center. In fact, he has been training most of the global organizations in how to conduct the clinical trials and the clinical research. Then I have got Dr. Gupta. Dr. Gupta is from Delhi. Dr. Vipul Gupta is awarded legendary figure in Internal Medicine 2017 trophy. He is a scope certified obesity specialist and honorary general secretary of Delhi RSSDI and joint secretary of RSSDI 2024, which just happened at Delhi. He has 30 and more national and international publications, and he is a founder of Gupta Ultrasound and Heart Care Center since 1997. And then my very close friend from Kolkata, the city of Mishti, Dohi, and Sandesh. He is like Mishti, Dohi, and Sandesh. He is Professor Dr. Udas Ghosh, former consultant at Fortis General Hospital and Apollo Hospitals at Kolkata, currently Vice President of National RSSDI, Governing Council member of our own association, that is Association of Physicians of India. And of course, he has multiple accolades. He has been a prolific orator. And the most important was, he was an organizing secretary of American College of Physicians India National Conference in 2021. So friends, without further ado, I would hand it over to Professor Hollick, sir, and we would like to love and hear him on one of our most favorite topics that we are going to talk about is vitamin D guidance, implications in the clinical practice. Over to you, Professor Dr. Michael Hollick, sir.
Well, thank you very much for your kind introduction. It's certainly a pleasure to have this opportunity to talk about vitamin D. It continues to be an exciting topic, and it continues to be actually quite controversial. And I am going to be talking about health benefits from inception until death, and talk about the 2025 perspective for clinical practice. People worry about conflict of interest, so I get support from a variety of companies and also from NIH. But much to the dismay of the dermatology community, I also get support from the sun. And if you want more information about vitamin D, you can go to my website, just drmichaelhollick.org. Now, you all know Dr. Marwah. He's a very close friend. I've visited with him multiple times, and I'm sure that he would be asking this question, is what am I going to tell you about vitamin D that you don't already know about? And you recognize this doctor very well. And the question, of course, is, am I really kind of an idiot? Because what do you know about vitamin D that you already don't know from the Institute of Medicine report of 2010, the VITAL study, and the 2024 guidelines? And so the Institute of Medicine, 2010, came out with recommendations. They realized that vitamin D really needed to increase at least not from 200 to 600 units a day. And they appreciated that you actually can take up to 4,000 units a day and not worry about toxicity. And that's really remarkable that an organization is able to do that. And the question is, did they get it right? And so in 2011, I chaired the Endocrine Society Practice Guidelines on vitamin D, and our objective was clear: for the evaluation, treatment, and prevention of vitamin D deficiency for patients at risk for deficiency. The Institute of Medicine, it was up to professional associations to make those guidelines, and they used a population model, not a medical model. So the recommendation from the Endocrine Society for infants, 400 to 1,000 units a day, children, 600 to 1,000 units a day. And I think that teenagers should be treated like adults, 1,500 to 2,000 units a day. And if you're obese, you need 2 to 3 times more. The 2024 guidelines came out, and it says, in contrast to previous guidelines that broadly addressed evaluation, treatment, and prevention of vitamin D deficiency, the goal of this committee was to develop and establish clinical guidelines for vitamin D to lower risk of disease in individuals without established indications for vitamin D treatment or 25-hydroxy-D testing. And they stated that they ignored association studies and only depended on randomized controlled trials. Now, many of you may know Dr. Semmelweis from 1800s, where he thought this was even a bad idea, right? So they recommend no vitamin D. They don't give any insight as to how much vitamin D an infant needs during the first year of life. They suggest 600 units for children, 600 units for adults up to 75, and 900 units for adults over age 75. And they don't describe any issue regarding obesity. Again, just to refresh, the Endocrine Society in 2011 for the treatment and prevention of vitamin D deficiency, and we recommended 400 to 1,000 units for infants, 600 to 1,000 for children, and 1,500 to 2,000 for adults, obesity 2 to 3 times more. So there's a big difference for the 2024 guidelines talking about vitamin D for prevention of diseases versus the 2011 guidelines for the prevention and treatment of vitamin D deficiency, of which the 2024 guidelines ignored. They stated that they weren't interested in that. So I've been talking about vitamin D, as many of you know, for well over 40 years, and people could not think of a more boring subject, right? But in fact, who is at risk of vitamin D deficiency? I think you're well aware, essentially everyone is. And it's important to recognize that rickets is only the tip of the iceberg for vitamin D deficiency, because the painful bone disease, osteomalacia, diabetes, multiple sclerosis, rheumatoid arthritis, infectious diseases, hypertension, heart disease, cancer, all associated with vitamin D deficiency. Vitamin D is essential for bone health. So I thought I'd bring you a case that you may not typically see in your own practice. 7-month-old female, muscle weakness, tetanic seizure, calcium half normal. Turns out it's the first lowland gorilla born in captivity at our local zoo. And it turns out that the infant is complaining to mom, bones are hurting, and the dad is very upset. So have you ever wondered what he was trying to say? That's what he was trying to say. Indeed, they suggested that they call me, and I recommended that this infant has rickets, and as a result, needed to be treated with vitamin D. 5,000 units a day, infant's feeling great. I was the guest of her first birthday, guest of honor for her first birthday. But bottom line, in utero and her first few weeks of life of vitamin D deficiency caused significant growth retardation. 2000, early 80% of infants with rickets in the 1900s had rickets. But is it a problem today? Yes. And I'm sure you see this as well, is that part of the reason is that it's suggested that human breast milk contains all the nutrients an infant needs. There's essentially no vitamin D in human breast milk. So if you give your infant human breast milk as a sole source of nutrition, that infant will be vitamin D deficient for that period of time. So can pregnant women be at risk because they're being followed carefully by their obstetrician, and they're given, of course, a multivitamin containing vitamin D? So we did a study at our hospital and asked the question, if mom is taking a prenatal vitamin, we looked at 40 mother-infant pairs, and we showed that they were taking 600 units a day. That's what's recommended by the Institute of Medicine and also now the 2024 guidelines for all women, including pregnant women. We showed 81% of newborns were vitamin D deficient and 76% of moms. Why should you care? Because we went on to show with Lisa Bodner that preeclampsia is associated with vitamin D deficiency. We know that vitamin D is critically important for muscle function, important for the birthing action. So when we looked at the association of vitamin D deficiency and the need to have a cesarean section, we showed that women that had the highest concentrations of 25-hydroxyvitamin D markedly reduced their risk of needing a cesarean section. So could they have been delivered without C-section? You better believe it. What about prematurity? Very nice studies showed clearly that there's a 60% reduction in premature births if the pregnant woman has a 25-hydroxy-D of 40 nanograms per ml. So mom, thanks for taking your vitamin D. Right? Also, it was shown that there's an inverse association with maternal 25-hydroxy-D and the amount of decay in infants during their first 2 years of life. Now, the 24 guidelines said that we suggest empiric vitamin D supplementation during pregnancy, given its potential lower risk for preeclampsia, intrauterine mortality, preterm births, small gestational age, and neonatal mortality. So you would think that this is fantastic, that the 2024 guidelines recognize the importance of improving vitamin D status during pregnancy. In clinical trials, it's suggested up to 2,500 units a day had this benefit. However, the panel focused generally on healthy populations, and they assumed that everyone was healthy and that only 600 international units a day was needed for 1 to 70 years of age, and they did not make a clear recommendation for increased amount of vitamin D for pregnancy. It's no question I recommend for pregnant women minimum should be 2,000 units of vitamin D a day. And if you want to have enough vitamin D in breast milk, you need to have the mom on 6,000 units a day. But infants have all been thought are very sensitive to vitamin D. They're going to wind up being very toxic. So how much do they need? The American Academy of Pediatrics recommends 400 units a day. Is it true that vitamin D is rare in foods? We showed even in the United States where vitamin D fortification has occurred in milk and other products for decades, that essentially no one in the United States can get enough vitamin D from dietary sources. And so, yes, it's a good source of vitamin D, but you would need to drink basically 20 glasses of milk a day to get 2,000 units of vitamin D. And India now, very nicely, are now recommending, and producers can add 770 units of vitamin A and 550 units of vitamin D per liter of milk. So it's a good source for vitamin D. And so I always tell my patients, and even infants, children, and adults, milk is a great source of calcium as well as vitamin D. And now that's true in India as well. Now, why is he carrying this mushroom around? Because mushrooms exposed to sunlight are very effective in making vitamin D. So sun-dried mushrooms are a good source of vitamin D. But most of our vitamin D is still coming from casual exposure to sunlight. And so in summertime, you're feeling great outside, having a wonderful time. But in the wintertime, it's a different story. The sun's rays are now much more oblique. And as a result, it has to go through a lot more ozone. And as a result, the UVB radiation is being absorbed by the ozone layer. How much vitamin D can you make? So we wondered about that, and we showed that in Boston, right here in July, August, you're making a lot. You begin to rapidly decrease the production. November through March, essentially nothing, and then it begins again in April. That's important because that means that in the wintertime, you're not getting any source of vitamin D from sun exposure. You need to get it from supplementation and or from your diet. You cannot make any vitamin D in the wintertime because many of my colleagues kept asking me, how prove it? So I finally proved it. And so it turns out that my daughter, she went down to spring break in Florida. And so she wondered, could she make it? Yes, she can. But you have to live basically above a latitude of 32 degrees north or below 32 degrees south in order to be able to make any vitamin D during about 4 to 5 months of the year. And the further north and south you go, it takes a longer time for the vitamin D process to begin. So you're thinking, of course, in sunny India, because when I had first arrived back 20 years ago, suggesting that vitamin D deficiency was an issue in India, I mean, basically everybody thought that was crazy. But we now recognize by Dr. Marwa's work and others that India is at high risk for vitamin D deficiency. Indeed, like I said, it's argued that if you go out in the early morning, you can make your vitamin D less damaging to your skin. It turns out that you can't make any vitamin D in the morning until about 10 a.m. to 3 p.m. We did a study with Dr. Harianan many years ago, and we showed here in Tirupati that at 8 a.m. you're making no vitamin D, 9 a.m. no vitamin D. You really begin to make it at around 10 a.m. and it abruptly ends at around 2 to 3 o'clock in the afternoon. Even though the sun is shining brightly at 5 o'clock in the afternoon on a summer day, you are not making any vitamin D, but you're getting blasted by UVA radiation, which is actually damaging to your skin. You know very well how to determine vitamin D deficiency. You measure your 25-hydroxy-vitamin D. And the recommendation had been that deficiency is less than 20, up to 100 is perfectly safe. But actually, docs, they don't worry about this. They want to know, is it high, is it normal, or is it low? And so typically at the end of the summer, when patients are coming back from a Cape Cod vacation, their blood level may be as high as 110. Are they vitamin D toxic? And so I explain, you know, I see some lifeguards in my clinic, not so much the Baywatch babes, right? They're at 110. Are they intoxicated? I don't think so. deintoxication based on the endocrine guidelines in 2011 said you have to get at least to 150 and usually above 200 nanograms per ml to worry about it. And so now, what about low? How do you know if you're vitamin D deficient or not? And so do you really need to be at least 30? And so we did a study with Ann DePape many years ago throughout the entire United States in postmenopausal women, and we related their PTH level with their 25-hydroxyvitamin D. We showed that if your blood level was 20 to 24, you had a 3 times higher risk of having secondary hyperparathyroidism compared to greater than 30. There was no evidence above 30 of any evidence of secondary hyperparathyroidism. So is vitamin D deficiency really a health issue, right? Am I at risk in sunny India? Adults at risk for vitamin D deficiency is overwhelming, right? And we've showed globally that 60% are insufficient and 40% are deficient. Now, Star Wars. I love Star Wars, and my favorite character is Jabba the Hutt. And this is what he's been trying to say. And no question, obesity is associated with vitamin D deficiency, right? And here are the data. BMI as a function of 25-hydroxyvitamin D. The higher your BMI, lower is your 25-hydroxyvitamin D. And we did a study to demonstrate that whether you take vitamin D orally or exposed to sunlight, so for a normal weight compared to an obese individual, it's about 55% lower blood level of vitamin D from either oral administration or from UV. Importance of body weight. So we did a study with Dr. Akwaru many years ago, and we showed very nicely, if you look at serum 25-hydroxyvitamin D and supplementation up to 20,000 units a day, look at this. For normal weight and look at overweight, they're basically the same. But look at obesity. You are much lower for the same dose of vitamin D. In fact, we calculated it was 2.5 times difference. And that's the reason for this recommendation that obese people need at least 2 to 3 times more vitamin D to satisfy that requirement. And recommendation 14 from 2024, in adults with obesity, we suggest against screening for 25-hydroxyvitamin D. But yet we know that they're at much higher risk and that you need to give more vitamin D. And the only way to know if you're going to correct it is you need probably baseline and then at least 8 to 12 weeks later to get another blood level. And so Endocrine Society recommendation, less than 20 is vitamin D deficiency, 21 to 29 insufficiency, and normal 30 to 100 nanograms per ml for maximum bone health. And greater than 100, you begin to be concerned about excess. So vitamin D deficiency, right, will precipitate and exacerbate osteoporosis, cause secondary hyperparathyroidism, increase osteoclastic activity. And as a result, you remove matrix and mineral because of the increased osteoclastic activity, therefore decreasing bone density, causing osteopenia that will progress to osteoporosis. And here's a very nice demonstration of this. This is what's happening when you're vitamin D deficient. You begin cavitating your skeleton and therefore decreasing bone mineral density, increasing risk for fracture. So subclinical vitamin D deficiency causes osteopenia and osteoporosis. Is it true that it can cause bone pain? It turns out that I saw many patients from referring physicians saying that my patient has bone pain, please evaluate for osteoporosis. Osteoporosis is a silent disease until you have a fracture, but osteomalacia is not, right? And so typically, it's always curious that your aches and pains occur in the winter. I wonder why. Symptoms: generalized bone pain, isolated bone pain, muscle aches and pains. Nouveau diagnosis, fibromyalgia, chronic fatigue syndrome? No. Many of these patients that I saw in my clinic, 40 to 60%, had classic evidence for osteomalacia. Here from the Mayo Clinic proceedings, here are children and adults presenting with aches and pains in their bones and muscles. 93% were found to be vitamin D deficient. Now, in 2022, supplemental vitamin D and incidence of fracture in midlife and older adults, the famous VITAL study. So I would like to review with you a little bit about it. And here's my good friend, Dr. Rosen, saying, based on that study, you could stop taking your vitamin D supplement to prevent not only osteoporosis, but major diseases, or even extend life. Right? A decisive verdict on vitamin D supplementation. And so mean baseline 25-hydroxy-D, right, total randomization, 64% were vitamin D sufficient at the beginning of the trial because they never measured the baseline and take that into account and then to give the 2,000 units of vitamin D. They took all comers and realized in the end that more than 50% were vitamin D sufficient and now getting additional vitamin D. And now they're asking the question, does it have any impact on decreasing risk of fracture? And if you look at those with a 25-hydroxy-D that's considered deficient by the Institute of Medicine, right, 87.1% had greater than 20 nanograms per ml, consistent for being sufficient for maximum bone health by both the Institute of Medicine and now the 2024 guidelines. And look at this, right? Only 2.4% were less than 20 nanograms per ml and considered to be deficient based on the Institute of Medicine. And so you have to realize that when you look at these data, there's no difference and not a surprise because essentially everyone was vitamin D sufficient for bone health. And so when they concluded that vitamin D supplementation doesn't significantly lower risk of fractures, you have to appreciate that they did not look at individuals that were vitamin D deficient. So this was not a randomized controlled trial by any stretch of the imagination. He's constantly complaining to his dogs, my bones ache, my muscles ache. The dog told him, stupid, you're vitamin D deficient. So with recommendation from the Endocrine Society in 2011, you want your level to be at least 30, maintain your bone density, decrease risk of fractures, improve muscle function, less likely to fall, less likely to fracture. So how do you treat it? Well, back in 1998, available in the United States is a 50,000 unit capsule. And I know in India, you have a 60,000 unit sachet. So I gave 50,000 units once a week for 8 weeks because what I wanted to do was to take that empty vitamin D tank and fill it up. And when we did that, we showed that it was very effective in raising circulating concentrations above 30 nanograms per ml. That's equivalent to 6,500 units a day. And then docs don't know what to do. So I told them, and I put my patients on 50,000 units every 2 weeks forever. Now, you may argue that you've been taught vitamin D is fat soluble. It's going to continue to build up in your body fat, and therefore you're potentially going to become toxic. Well, Einstein worried about this. So we looked and did a study for 6 years follow-up, and we showed on 50,000 units every 2 weeks for up to 6 years, their circulating concentration was in the range of 40 to 60 nanograms per ml, and there was no toxicity or any untoward complications. That's equivalent to 3,300 units of vitamin D a day. 1,000 units a day. We did a study in healthy adults in Boston in the wintertime. Will not make you sufficient. So can you give 60,000 twice a month without screening? Because you don't always have available to you, right, the 25-hydroxy-D assay. And so we did another study. And I took all comers coming to my clinic. I put them on this program, got their blood level at the beginning, and then 6 years later. And so the Endocrine Society in 2011 reported this, and we showed This is with a baseline, right? Up to 50 nanograms per ml. Some had up to 50 on 50,000 units twice a month for 6 years. Their level didn't increase more than about 80 nanograms per ml. There was no toxicity. Recommendation 11 from 2024 guidelines. Adults aged 50 years and older have indications for vitamin D supplementation and treatment. We suggest daily lower dose vitamin D instead of non-daily higher vitamin D. Once every 2 weeks works perfectly fine. And for elders who don't want to take a pill every day, it's a good option. I prefer personally to take it every day, but certainly giving it every 2 weeks or once a month, very high dose, you can be successful in correcting D deficiency without any toxicity. Can you become toxic where you have an elevated calcium, phosphate, calcify your blood vessels? And so we did a study with Bob Heaney many years ago. We gave healthy adults up to 10,000 units a day, and we showed that there was no significant change in urinary calcium. It was perfectly safe. Study done out of Canada showed in Akwaru that 4,000 to 5,000 units a day gets your blood level in the range of about 30 to 40 nanograms per ml, right? 20,000 units a day, 60 nanograms per ml. It's equivalent to taking 120 to 150,000 units a month, or equivalent of 600,000 units a month. What about infants and children? And so a study was done by Dr. Gordon many years ago, and she treated neonates and infants and toddlers 50,000 units once a week for 6 weeks, and then 2,000 units thereafter. So 2,000 units is perfectly safe. Also, pregnancy, Bruce Hollis and Carol Wagner showed 4,000 units a day was very effective in raising that blood level in the range that reduces risk for premature births and other benefits. And they showed that urinary calcium levels did not change. There was no consequence for this, and the serum calcium didn't change either. But you can become toxic. This product was on the market back in the 1990s, and it was said to have 1,000 units in a teaspoon. And I got a phone call from a patient down in Florida saying that he had followed my advice, was taking 2,000 units a day, and became toxic. He was a lawyer. And I told him, that doesn't make any sense. Send the product up and we'll do an analysis. The company forgot to dilute it. He was actually taking pure crystalline vitamin D, 1 million units a day. This will cause toxicity. In fact, we published him, New England Journal of Medicine. We had 25-hydroxy-D of over 500 and a severe hypercalcemia. I took him off all vitamin D, good sunscreen use, and his 25-hydroxy-D gradually came down, and he had no complications from that experience. It's difficult to become vitamin D intoxicated. So why should you care about all this? Well, as you know, vitamin D is made in your skin. You get it from your diet, goes to your liver, converted to 25-hydroxy vitamin D, and then to the active form, 1,25-dihydroxy vitamin D. And yes, it regulates calcium and phosphate metabolism. But what's remarkable, over the past several decades, we now recognize that the vitamin D receptor exists in essentially every tissue and cell in your body. Why would they be there if they weren't having an effect? In 1979, Suda had showed many years ago leukemic cells that had a vitamin D receptor. If you incubated them with active vitamin D, they became normal. So that introduced the concept of vitamin D in cancer. And clearly, vitamin D deficiency, sunlight deficiency, has been linked to increased risk for deadly cancers. It's been estimated by Garland that a 50% reduced risk of colorectal cancer just by increasing your intake by 1,000 units a day. Here, my good friend Cliff Rosen, he said, what else can you? And is there any non-calcemic health benefit in light of the VITAL study? Remember, again, the VITAL study, right? Most started out with a 25-hydroxy-D of greater than 30 nanograms per ml. 55.1% had optimal levels. And here's Dr. Manson, right, saying that there was no benefit in reducing cancer or cardiovascular risk. But she noted, whoa, if you look at cancer mortality, 25% significant decrease in cancer mortality. That's quite remarkable, right? And she said, and it may take longer for cancer to grow, so maybe that's why they didn't see any benefit of 2,000 units a day for the VITAL study. Then this paper came out, 2019, and it said that giving 2,000 units of vitamin D a day to patients that have some digestive cancer underwent both chemotherapy and or surgery, that it did not have any impact on improving survival. And as a result, it was concluded 5-year overall survival, 82 versus 81, no benefit. And there are the data. Well, when this came out in 2019, that was it, right? That patients on vitamin D, no significant improvement. Is that the final straw? Is that the final nail in the coffin for vitamin D? Well, thank goodness. It turns out, if you look at subset analysis, those that were most vitamin D deficient and were treated actually had significant improvement compared to the group that were vitamin D relatively sufficient. And so as a result, this group went back and did another study, and they looked at supplementation on relapse or death, looking at P53 immunoradio reactivity. And so the question was that if a patient was now developing antibodies against mutant P53, which can occur in about 50% of all cancers, is that helping vitamin D then to fight further activity of the cancer? The vitamin D group, 80.9% had relapse-free compared to 30% of patients if they had P53 immunoradioactivity. And this is the reason why. P53, as you know, is a molecule that controls cell growth. And 50% of human cancers carry these mutations. And the cancer is not stupid. It mutates this, and it actually helps the cancer to grow. And it prevents vitamin D from working. Very clever of cancer. But if the body is able to mount an immune response to the mutant P53, all of a sudden, you have a marked increase in relapse survival. What about immune system? We know that inactivated T lymphocytes have no receptor. You activate them and they do. They respond to 125D with marked effect on proliferation and on cytokine production. B lymphocytes, resting, no vitamin D receptor. When you activate them, they do. Well, why? Because 125D will now modulate immunoglobulin synthesis, and we believe it does it mainly for the purpose of decreasing autoimmune activity. We know that macrophages can activate vitamin D. Have you ever wondered why? We now know why, right? Back in the 1800s, cod liver oil was used and to treat tuberculosis. Vitamin D protects against TB. And Maudlin, Adams, and Liu published 2006 a remarkable paper, toll-like receptors. When you're infected with an infectious agent, whether it be a virus or here tuberculosis, toll-like receptors are turned on. And what happens? Once that occurs, it induces the macrophage to increase 1-hydroxylase activity, converting 25-hydroxyvitamin D to 125D. Why is that important? Because 125D then gets back into the nucleus and tells the cell to increase expression of cathelicidin. And as a result, cathelicidin, a defensive protein, will lyse bacteria and will cause and lyse viruses and decrease infectious activity. It's well documented that if you lived above 5,000 meters, like in Switzerland, you didn't get tuberculosis. And those with tuberculosis exposed at higher altitude where they can make vitamin D help prevent it. We know that the flu season always occurs in the wintertime, including now COVID, right? So at the peak flu season is when your 25-hydroxyvitamin D levels are at their lowest. And so a study was done here out of Yale, and they showed that adults who had maintained a blood level of 38 nanograms per ml reduced risk of upper respiratory tract infections twofold. Here, a study out of Japan showed school children, 1,200 units a day just during the wintertime, reduced risk of influenza A infection by 42%. And by the way, when you go and look at that paper carefully, it reduced risk of asthma attacks by more than 90%. So what about COVID? And it turns out that many studies have now been done, one of which we did early on. And we asked the question, if you're COVID positive and your vitamin D status, how do they relate? If you're vitamin D deficient, are you at higher risk of having COVID positivity? So working with Quest Diagnostics, we looked at 191,000 plus patient samples, and we showed that if your circulating concentration when you had the test done at 34 nanograms per ml, 54% reduction in having COVID. Also, very nice study that was done out of San Francisco by Dr. Dan Bickley's group showed 22% lower mortality, risk of infectivity and mortality by 45%. We know that innate and adaptive immunity is controlled by active vitamin D. It's a major immunomodulator. And so here we have, again, Cliff Rosen saying, you don't have to take vitamin D supplements to extend life because it has no benefit. But now a study was done looking at the vital data and wondering, is there any evidence that greater than 30 is good for health? And Joanne Manson's group reported that when looking at the vital study and autoimmune risk, they were amazed to find 22% lower risk of autoimmune disorders. And what's really quite remarkable is we're talking about disorders like rheumatoid arthritis, as well as psoriasis, and other autoimmune disorders, 22% reduced risk. And here are the data that clearly demonstrated. Here's a nice study that Dr. Munger had published many years ago. Women that had the highest intake of vitamin D reduced risk of MS 41%. A study out of Iowa showed 44% reduced risk for developing rheumatoid arthritis. Here, a study done in Finland many years ago, children were getting 2,000 units a day during their first year of life because they were worried about the fact that they lived at such a high latitude that they weren't making any vitamin D. It showed that when you followed them for 31 years, it reduced their risk of getting type 1 diabetes by 88%. Now, here's a recommendation from 2024 guidelines, and that is clinical trials, right, suggest that vitamin D supplementation will reduce risk for not only rickets, but infectious diseases. And they suggest, however, that everyone 1 to 70 years of age be on 600 units of vitamin D a day. So even though they said that children can benefit from this by up to 1,200 units a day, their recommendation in the end was take 600 units a day. What other evidence? Turns out that your beta islet cells have a vitamin D receptor. 125D stimulates insulin production. And there's good evidence it reduces risk for metabolic. And a study done by Pittas many years ago showed if you increase your calcium and vitamin D intake from the National Health Survey, relative risk reduction for developing type 2 diabetes, 33%. However, Here we go with a study that was done then by Pittas later on, looking at whether or not giving vitamin D to individuals that have pre-diabetes, 4,000 units a day, is it going to reduce the risk of progressing to diabetes? So it was based on his early epidemiologic study. And what did they find? No benefit. Haha. But it turns out that remarkably, if you look at those that had a blood level of at least 50 nanograms per ml, compared to those that had 20 to 29 nanograms per ml baseline, 76% with a 3-year absolute risk reduction of 18.1%. So 25-hydroxyvitamin D, raising that blood level in that range, has definitely appeared to have a significant benefit in reducing risk of prediabetes progressing to diabetes. Here, the recommendation again from 2024 guidelines suggests that for diabetes, in addition to lifestyle modification, we suggest empiric vitamin D supplementation. And how much? Up to 3,500 units a day. But again, go back into the recommendation. They don't recommend that for the general population. But yet, we know in the United States, 50% of the population in the United States have either diabetes or prediabetes. To me, that was a missed opportunity. CDC estimates 50% of the US population has either diabetes or prediabetes. 76% reduction in 3 years, absolute reduction risk 18.1%. That's dramatic. What about heart health? Right? Study done many years ago from the National Health Survey data showed the higher your 25-hydroxyvitamin D, lowers your risk by 80% if you're greater than 30 nanograms per ml. We also know mechanistically that vitamin D improvement will regulate up to more than 200 genes in the cardiovascular system, controlling atherosclerosis production, blood pressure control, and left ventricular activity. Here, out of the Framingham Heart Study showed first MI greater than 50% increase associated with a 25-hydroxy-D of less than 15 nanograms per ml. Can you live longer? Right? And everybody wants to live longer. And so all-cause mortality was shown. If your 25-hydroxyvitamin D was greater than 30, 25% decrease from this study out of Germany. Recommendation 6. In the general population, 75 years and older, suggest empiric vitamin D supplementation because of the potential to lower risk for mortality. Well, in a review that I wrote in response to the 2024 guidelines, I pointed out to them, you don't start increasing your mortality when you reach the age of 75, right? It's because of your poor health earlier that increases your risk for mortality. So increasing your vitamin D intake, in my opinion, from 600 to 900 units a day is not very meaningful. But that's what was suggested, right? And here are the data. Here from the Garland brothers, they showed if your blood level is 40 to 50 nanograms per ml, you reduce your mortality substantially by almost 90%. Vitamin D deficiency is a disease of neglect. Adequate vitamin D is critically important, not only from birth until death, but from inception until death. A mound of evidence linking vitamin D deficiency with a multitude of chronic and acute illnesses. Here in Delhi, like I said, Dr. Marwa and his team showed vitamin D deficiency, a very significant health problem, including newborns, 16 nanograms per ml. Disease burden, stunted growth, and type 2 diabetes, hypertension, fracture risk, and common cancers and autoimmune diseases. Don't think about a normal level, but think about a healthy level. And how can you determine what the optimum level should be? Well, good insight would be to our hunter-gatherers. What were they thousands of years ago? Well, happily, we still have hunter-gatherers. And here are the Maasai herders, for example, and a picture that I took when we visited with them and my daughter. Their blood level is 40 to 50 nanograms per ml. And you would have to take 4,000 to 5,000 units of vitamin D a day to achieve that. Goal, in my opinion, should be at least 30 nanograms per ml. 40 to 60 is a preferred range as recommended by the Endocrine Society in 2011. This is your problem. So how much vitamin D do you need? And it turns out, curiously, that once your blood level is at around 20 nanograms per ml, for every 100 units you ingest, you raise your blood level by a 0.6 to 1 nanogram per ml. So if you're in this range, and I guarantee that you are, if you're not taking vitamin D supplementation, 1,000 units a day will not make you sufficient, right? Minimum I recommend for adults, 2,000 units a day. Children, 1,000 units a day. Conquer vitamin D deficiency. Best source, sunlight, right? Ancestors very much appreciated the beneficial effect of the sun. Dermatologists had a different view. Dermatologists always advise you to wear sun protection. Have you ever wondered, if you've ever been on rounds with an unenlightened dermatologist, what they're trying to say? Right? Never be exposed to one direct ray of sunlight. That's what the American Academy of Dermatologists in the United States still recommends. I think Charles Schultz had good insight into life, and his Peanuts character gives a good insight. It says, good grief, another note from his mom as he's sitting in school on the outside. Are you sitting in the sun? I hope so. A little sun is good, as long as we don't overdo it. Perhaps 10 minutes a day. This time of the year is about right. No question, moderation is what we need. Sunlight is very effective in helping to give us some adequate vitamin D. This is what's happened to our sun. It's been demonized now more than 50 years. Never be exposed to sunlight. Happily, now the Dermatology Society in England and even Australia and New Zealand, they now recommend sensible sun exposure, as does the World Health Organization. Slip-slop message in Australia, 40% of Australians are vitamin D deficient, right? Who's that? That's an Australian dermatologist on vacation, right? Wearing sun protection all the time. They're all vitamin D deficient, right? 87% deficient at the end of the summer, right? Vitamin D deficiency has been associated with schizophrenia, depression, dementia, and even Alzheimer's disease, right? Our brain has a vitamin D receptor. Also, there's some data, at least in animal studies, to show that in vitamin D deficiency, if you improve vitamin D status in rodents, it improves serotonin levels, makes them feel better. And so there's a variety of consequences of being vitamin D deficient in the central and peripheral nervous system. You can get it from your diet. That's what we've been taught. You cannot get enough vitamin D from your diet, right? So what do? I recommend that the best source, of course, is sun exposure, but time of day, season, latitude, weather conditions, how do you know what to do? Well, there's only one thing to do, right? Is to develop an app, which we did working with Ontometrics. You can go to dminder.info. It's free on your Android and on your iPhone. And in India, it will tell you when you could begin making vitamin D, how much vitamin D you make, and it even warns you to get out of the sun so you don't get a sunburn. What do? Sun protection on my face, but none on my arms and legs. And I take 6,000 units of vitamin D a day. And my blood level is in the range of 70 to 80 nanograms per ml. Vitamin D deficiency is the most common medical condition worldwide. If any one of these chronic illnesses, right, including autoimmune disorders and infectious diseases, including COVID, related to vitamin D deficiency, right, there's no downside to increasing your vitamin D intake. You don't need to be a genius to know this. We need sensible sun and supplement recommendations. It's not a hypothesis, right? Should you screen everybody? The Endocrine Society in 2011 and now in 2024, we do not recommend screening. But if you're obese, pregnant, have sarcoidosis, have sensitivity to vitamin D, you definitely need to be evaluated for their vitamin D status. So vitamin D association studies were ignored by the 2024 guidelines. And so I was asked by Endocrine Practice to revisit the vitamin D guidelines for 2024 and gave a critical appraisal of the literature from my opinion. And here are the data, and I decided I would actually show graphically what's going on. Parathyroid hormone, serum 25-hydroxy-D for bone health. Definitely you're at higher risk of osteopenia and osteoporosis if you're less than 30. Osteoid volume, based on the Primal study, showed you have no osteomalacia in your bones if your blood level is greater than 30 nanograms per ml. Here, greater than 60 nanograms per ml reduce 60% reduction in preeclampsia risk. Again, here, premature births, greater than 40 nanograms per ml, 62% reduction. Prevalence ratio for peripheral artery disease, which I showed you, 80% reduction. Blood level greater than 30 nanograms per ml. Here, COVID, right, 54% reduction in acquiring COVID infection if your blood level is greater than 34 nanograms per ml. Breast cancer, greater than 52 nanograms per ml, 50% lower risk. Here we go, mortality, right? Greater than 33 nanograms per ml in this study showed 90% reduction. And I listed in this review all of the possible benefits of vitamin D, right? A good example, prediabetes to diabetes, 76%. Autoimmune disorders, 39%. Cardiovascular mortality, 67% reduction. They're all above 30 nanograms per ml to be able to benefit from these health activities. I wrote a book called The Vitamin D Solution. There's no question that vitamin D can improve your health. And I thank you for your kind attention.
Wow, Dr. Holik, that was extensive and absolutely mind-boggling. You presented your original work. Friends, you must appreciate that also Dr. Holik is responsible for the first clinical assay, which has been shown to, have a conversion from 125 hydroxy to 125 dihydroxy to 25 hydroxy, and the mechanisms by which the vitamin D is synthesized in the skin. But he's also a person who has demonstrated that not only its skin, but even macrophages and prostate can make vitamin D. Now, with that appreciation, sir, I would request you to stay back and request all my audience to put their questions. And of course, I would now invite my mentor, my very close friend, my buddy, my brother, chairman of IDF Southeast Asia, Professor Dr. Banshi Sabu, to talk about what briefly Dr. Holik alluded to, the relation of diabetes and vitamin D deficiency, what we take in India, what are the advices, what is the rational, what is an evidence, and what are the practices. Over to you, Dr. Banshi.
Mangesh, first of all, thanks for this wonderful opportunity. And I must thank API, D Conclave, IJCP, and Alchem for this wonderful support. But after listening from Michael Hogg and then, to talk in front of him, it's really extremely difficult. And I don't think there is any need to talk also. Rather, we should discuss more. So I will be very quick and finish my presentation within 10-15 minutes, because we want to learn and ask more questions to Dr. Michael rather than to waste all this thing. So I'll be very, very quick and very fast. Let me share my slides. Can you see my slides?
Yes, Banshi. You need to make it a full screen.
I'm doing it. One thing COVID taught us that, we can now do online meeting and So once again, thanks API. Thank you, Mangesh. Thank you all the panelists. Without wasting much time, what I am going to talk in diabetology, vitamin D, and in clinical practice, we have evolving evidence and practical application. I will be talking the Indian paradox, which we know, and he had already talked about it. The health benefits of vitamin D. Again, he has talked about it. What the understanding of 7 Ds of vitamin D supplementation? What's the clinical strategy? Hypervitaminosis, which is a very, many people they are worried of it, but Michael had very clearly told that hardly anyone you will find who will have hypervitaminosis. Implementation in clinical practice and key takeaways. That's what I'm going to talk. This Indian paradox, we all know that even we have abundant sun, but yet widespreadly vitamin D deficient. In one of his slides, he had very clearly showed that, in India, hardly we will find a persons with normal vitamin. And this is what we had seen in our clinical practice. And I'm sorry once again that I want to finish it as early as possible because I also want to ask a lot of questions to Dr. Michael. The prevalence is highly prevalent in adults, and as a Southeast Asia chair for International Diabetic Federation, I can say very clearly that even for South Asian countries, it is also highly vitamin D deficient. If you ask that prevalent in almost 490 millions in Indians, and he has talked very rightly that it is one of the most common disorder. I was thinking it is anemia must be the most common, but he is very rightly said it is the vitamin D deficiency is very common. The health benefits. We all know about the health benefits of vitamin D, which he has talked. But what is more important is about immunomodulation, which is preventing autoimmune disease and controlling of invading pathogens. This is something we should know as a clinician. Regulation of cell growth and differentiation. They are the work which works at the different organs. Other than that, what we are knowing about the more bone and muscles. We all know about the calcium, muscle health, bone health, blood pressure regulation, CV health. Also, there are a lot of data. But he also talked about the neurodevelopment and even schizophrenia and Alzheimer's disease and depression and so many things which has been correlated with vitamin D. The health benefits from the calcium and bone homeostasis, every one of us we know. But these are the different systems where you can talk about the immune system, hormone secretion, mortality, even longevity. And he has also talked very nicely about the longevity, brain, metabolic syndrome, the cancer, the skin, the cardiovascular events, the muscles, reproduction, and lungs. Almost you can say every organ of our body and every system of our body is having effect of vitamin D. And it has been shown that not only deficiency is the reason for them to increase in incidence, but also by giving them a proper vitamin D deficiency which they have, if you give them vitamin D supplementation, there is shown improvement also. And he had shown multiple papers of him and also many more papers which are published in different areas. The health evidence, we have the literature evidence that health benefits are skeletal to extraskeletal. And this is what we want to teach our people from our physician community, that it is the primary hyperparathyroidism. It is a low vitamin D deficiency, is a common in patients with primary hyperparathyroidism. That is also there. And 2,800 vitamin D daily for 52 weeks. Pre and post parathyroidectomy, you will see the vitamin D level to increase, PTH is to decrease by 70%, 17%, increase in lumbar spine bone mineral density by 2.5%, decrease in C-terminal beta cross-lapse by 22%. So daily supplementation with high vitamin D dose is sufficient, safe adjunct that reduce post-op hungry bone syndrome. So this is what in a patient who are primary hyperparathyroidism. In metabolic syndrome, and I'm sure as a diabetologist, as an obesity physician, we have seen this slide multiple times that in metabolic syndrome, the role of vitamin D is very, very high and we use it also. These are the different clinical trials. Again, I will not go much in the detail of it. You can see from 2019-17, I put a lot of clinical trials. And on the right side, we had talked about how metabolic profile, including cholesterol, HbA1c, and blood pressure, they are decreased, and there is a improvement in other metabolic risk factors too. These are some of the trials which are in obesity and overweight people. As he had said that in people who are obese and overweight, the requirement for vitamin D is very high. So this is something more interesting to know, that in normal people, and now we are becoming more and more overweight and obese people, there also he had shown the benefit of this as a in metabolic profile to improve. In type 2 diabetes, it is significantly associated. The deficiency is associated with increased occurrence of type 2 diabetes, particularly in adults who are above the age of 45. Low level is been correlated with higher A1C and higher insulin resistance. And by giving vitamin D, you are actually boosting pancreatic insulin secretion, you are protecting beta cells, you are promoting depolarization and regulating the function of calcium binding protein on pancreatic beta cell. It improves insulin resistance also. So this is what in particularly in vitamin D in diabetes. These are the some of the clinical trial which has been shown in people with pre-diabetes, with diabetes, with high insulin resistance. And here you can say on the right side that how the metabolic profile of a diabetic patient by decreasing HOMA-IR, by decreasing HbA1c, by decreasing triglyceride, increasing in HDL, they had been shown. And then there are different clinical trial which I am showing here on the left side. Actually, vitamin D is a vitamin or it's a hormone. We know that it has got a multiple effect. So we can say it's a hormone which is been known as a vitamin. It inhibits the synthesis of some inflammatory cytokinins. It promotes monocyte differentiation in macrophages, increase phagocytosis and chemotaxis. It acts as a mediator in ameliorating insulin sensitivity. It inhibits the process of adipogenesis. So, it has got the work in thyroid, in diabetes, in obesity. We know that these are the three most common endocrine problems which we see in day-to-day clinical practice. And what I have shown on the left side that how vitamin D is effectively can be used in these clinical conditions. The health benefits is other than what metabolic syndrome, viral hepatitis B, something autoimmune thyroid disease, combined endocrine disorder, cancers, and these are the conditions which we normally we will never think that they are also the people who are vitamin deficient. I mean, probably the oncologists, the immunologists, and the people with hepatologists, they all should use and see that vitamin D level in their patients also. The health benefits for CVD we had talked, but vitamin D at adipogenesis, apoptosis, oxidative stress, inflammation, secretion of adipocytokinins, lipid metabolism, thermogenesis, everywhere you will see the role of vitamin D in adipose tissue. The potential extraskeletal benefits of vitamin D supplementation, the central blood pressure, the all participant for lung functions. You see the people with asthma and COPD. You see the people with who are prescribed NSAID or progression of from pre-diabetes to type 2 diabetes. It means also for diabetes prevention also. And here again, I'm not going in the author's details in the different clinical trials, but here you can see very clearly that some of the places even it had shown a very significant p-value also. The understanding the 7 Ds, that is what most commonly very important for all my clinician friends, because when you go and give a talk to your primary care physician or a general practitioner, you can say that demand for vitamin D is very, very important and it's very high. That's the reason WHO put in a model list of medicine in 2021, the national list of essential medicine in 2022. The doses, he had very rightly said 2,000 units per day. And I think with Indian pharmaceutical, they are very smart to come out with a 60,000 instead of 50,000 units. And we give them a maintenance dose of 60,000 units per month. And I tell all my patients when I treat them for deficiency, once in a week for 12 to 16 weeks, depending on the deficiency. And I put it maintenance dose once in a month, lifelong. I never say that it should be stopped after some time. Symptomatic, we know that how we weekly give. When we have patient with a asymptomatic and symptomatic, that again, dynamics, the recommendation for supplementation should be indication based. Delivery, the ease, because we have vitamin D sachet, we have tablet, we have capsules. Desirability, this is what 40 to 60. And Michael had talked already that this is what the desirable. At present, more than 30, we consider it sufficient, but desirable level is 40 to 60. It requires education and awareness. I think if we tell the patients 1 minute more and 30 seconds more about vitamin D, many of your patients will able to listen it and they will continue to take also. This is one a expert consensus, which is Sanjay was the first and many of the national experts from all over India. It's been just published and they talked about the vitamin D in 2025 when they published in our Indian International Journal of Endocrine Metabolism. The standard deficiency is less than 20, severe when less than 10, and many of our patients, when we get it done, it comes 3 or 6. It is not like that we are getting for many of our patients more than 10 also. Insufficiency, yes, definitely less than 20 to 30. And this insufficiency report, Mangesh, I see many of our people who come actually with they are taking vitamin D actually, and they come with a 25, 27, but they are not regularly taking as per the doctor who had advised. But we desirable level which we want them for 40 to 60, I think they should take regular supplements. How to achieve this? Again, vitamin D for those patients who are sufficiently, which I do in my clinical practice once in a month. Insufficiency, you give it for 8 weeks. Once sufficiency is achieved, transition to once in a month. Vitamin D deficiency, it means less than 20, you give them once a week for 12 weeks. If I get less than 10, we give it even for 16 weeks also for the same. This is what the age is specific. With the children, as he was talked very rightly, that people were not writing it, but now neonatologists and pediatricians also know that it is required, and they were understanding only from the decades point of view, but from growth and for all the points, it is very much required. So for 400 international units per day for the neonates, for the children aged 0 to 6, for children aged between 6 to 12 months, it is again slightly increased up to 600. In healthy children from 1 to 3, it is again 600 units per day. For 4 to 10, it is 600 to 1000. And in children aged 3 years and above with confirmed vitamin D deficiency, again, they should be given 60,000 units once a week for 6 weeks. And why I talk more about it? Because someone had asked the question that what should be the dosage so they can take the photograph also. And this is what the expert consensus. In healthy adolescent, this is the same which we had talked. 60,000 units should be given once in a week for 6 weeks. An elderly patient, this supplementation can be increased empirically. A specific patient may require higher dose. Those who are underweight, so in compared to obese people, the people with normal weight and underweight, their requirement may be low. Women planning pregnancy, women with confirmed pregnancy, with breastfeeding. Again, here already talked, so I need not to talk because this is what we have recommended based on the paper and references which has been, we had used what Dr. Michael had talked about those papers. The high risk conditions which need more or they need routine vitamin D supplementation like cerebral palsy or neuromuscular disorder. I'm sure our neurophysicians colleague, they're right, but still because they are focused more on, some of the very specific things, sometimes they forget to write. And I think there how the physician role is very, very important in chronic kidney disease, in chronic liver disease, in malabsorption. Most of the time I have seen the nephrologist write, but other specialists, normally sometimes super specialists forget. Malabsorption, chronic use of glucocorticoids, anti-epileptics, ketoconazole, endocrine disorders like hyperparathyroidism, and disease with extensive cutaneous involvement, they need or they are the actually high-risk condition where routine vitamin D supplementation should be done. Population with higher vitamin D needs, these are the musculoskeletal disorders, systemic connective disease, steroid-induced, other metabolic condition, malabsorption syndrome, endocrine conditions, kidney disorder, cancers, immunocompromised, and even CNS system, which he had already talked about, Alzheimer's, Parkinson, multiple sclerosis, dementia, and today I heard of even schizophrenia too. Vitamin D deficiency prevention strategy in high-risk population. The best thing is to screen everyone. That is what, if you really want to establish that whether they are insufficient, they are deficient or severely deficient. As per that, you give them dose as which is recommended. Very simple, 60,000 units for 12 weeks and then once in a month to be maintenance dose. If you just wanted to give for an empirical supplementation like an immunocompromised patient, even you can give once in a month for all those patients to whom you wanted to give. There is an algorithm with the patients who have vitamin D sufficiency, vitamin D insufficiency, symptomatic plus minus, and deficiency. And this is what a chart, which again, everyone can take the photograph. This is what we had talked. But in follow-up, the reinforced need for healthy diet, lifestyle adherence, and persistence with the therapy. Now, most important part is here, other than the lifestyle modification, is the persistence with therapy. Because many of the patients, they feel that this is a course only for given for few months or few weeks, and they don't take it lifelong as a maintenance dose. Many of the time, the primary care physician to super specialist, we also forget to write it that this is the maintenance dose which they should take probably for lifelong. Yes, there is a hypervitaminosis, and many of our friends, they are really worried. And to be very frank, we have hardly seen a patient with a hypervitaminosis, but it can have a clinical manifestation. This is what in a theoretical conditions, you may have a patient with a nervous system issues, with a confusion, psychosis, coma, but they may also have GI problems or GI complaints. They have musculoskeletal system, which is weakness, bone pain, muscles and joint pain, renal system with a hypercalciuria, nephrocalcinosis, polyuria, dehydration. They all are hypercalcemia induced symptoms. So this is a typical of a clinical manifestation of all hypercalcemia, which you will see. But one condition which is really very important for clinician to understand, that hypergranulomatous disorder, like in lymphoma or during an idiopathic infantile hypercalcemia, the hypervitaminosis may lead to a hypercalcemia condition or a clinical manifestation of vitamin D toxicity you may find in your clinical practice. So what's then implementation in clinical practice? How you will bridge the gap? One side you are talking that everyone is vitamin D deficient, on the other side, we wanted to give everyone vitamin D. So one is we have to increase the public awareness. And this, I again congratulate here EPI that, today we are meeting online and we can reach out to thousands of physicians. And even in the rural area, otherwise they normally don't come to any clinical, in a conference or a meetings, major meetings. So this is one way how we can addressing this knowledge gap and creating a public awareness. So again, next time, on some social platform also we can meet Mangesh, and we can do a on vitamin D to everyone, integrating vitamin D into a national health program. This is what the government or ministry where this should be done. A role of healthcare professional. What we can do educate the patient. We can talk about the dietary resources and sun exposure and supplementation. We can talk about the routine inquiries which can come on a social media. We can do a community level screening and awareness level initiative, like we are doing random sugar. Even it can be also done, vitamin D checking can be done at large. So in nutshell, the key takeaways, despite India's tropical latitude, vitamin D deficiencies remain very prevalent across all age groups. And this is underscoring a clear disconnect between a sunlight exposure and a biochemical insufficiency. So this is most common. People think that, we have so much sunlight exposure. Vitamin D deficiency continues to be underdiagnosed. And I will say not only underdiagnosed, it is undertreated. Even in a conditions when people are going to a doctor, super specialist, physician, still diabetes, obesity, metabolic syndrome, all your patients you will find vitamin D is less. Vitamin D improves insulin sensitivity, it improves beta cell function, it decreases systemic inflammation, it is adipogenesis and immune function it improves, and possibly decrease cardiovascular risk also. There are meta-analysis, randomized control trial, Mendelian randomization study demonstrate vitamin D supplementation in glycemic control, in lipids modulation, in reducing inflammatory markers, in type 2 diabetes, as well as in metabolic syndrome. Guidelines recommend maintaining, that is what, 40 to 60, that is desirable level. I again say it's a desirable level. Dosing must be very much personalized. Physiological status like pregnancy, requirement may be more. With comorbidity, the requirement may be for few weeks. It can be once in a week, then it can be once in a month. If you are not giving on a daily dose basis, despite well-documented benefits, there is a clinical inertia remains a barrier. Now, I don't think a clinical inertia. I think it's more of an awareness and knowledge. And we just forget. We write all these things, but at last, when we want to write vitamin D, sometimes we forget or we don't explain the patient properly. So there may be a reason for a non-compliance. A standardized algorithm, a very simplifying monitoring can help. And they will teach these patients once they will be taught about the vitamin D. Probably many of your patients will have a corrected and a sufficient amount of vitamin D in their blood level, and that will help them a lot. With this, I thank, and there should be a call to action. There is a include vitamin D screening for all your patients. Apply Indian specific evidence-based protocol. Incorporate very flexible design, which is monthly and weekly. Again, I thank Indian pharmaceutical industry by giving us 60,000 units. Educate and counsel the patient, and champion preventive care by advocating supplementation for at-risk individuals. With this, I thank once again, thank you, Mangesh. And again, very, very thankful to Alchem and API for giving me this wonderful opportunity. And we'll love to hear more from Dr. Michael and with our panelists. Thank you.
Wow, Bansi, that was crisp and that is super champion as you
I
know.
was very fast. I'm sorry for
No. In fact, that was superb, and it was very crisp and clear messages. Excellent. Before I start going to our panelists, let me have a privilege of asking the first question, and that is a very common question that we keep on encountering in our day-to-day clinical practice. Is this that, Professor Holick, what is your recommendation on the injectable vitamin D depots that are being usually recommended by our orthopedic colleagues to manage this, symptoms and myalgias, especially when
Yeah.
the patients, they have severe vitamin deficiencies below maybe probably 10 nanograms per deciliter.
So you probably are aware that back in the 1930s, they had the Stultz treatment for rickets. And the reason being that when they would see a rickety child coming into the hospital, not likely they're going to see that child again. And so they gave very high dose, like hundreds of thousands of units of vitamin D. And it really was very effective in preventing vitamin D deficiency and correcting vitamin D deficiency rickets. And so it's very reasonable, in my opinion, to take vitamin D daily, ideally, but every 2 weeks or once a month is okay orally. Injecting wise, there are two issues. In the United States, it's not available because the formulation was not approved by the FDA. So in the United States, some pharmacies will make it, but it's not available as a pharmaceutical. It works, and it depots, in the muscle, and it's in a formulation that releases the vitamin D relatively slowly over time, and therefore, just like what was done in the 1930s, if you're concerned that you're not going to get to see that patient again for 6 months or a year, it's a very reasonable approach to guarantee vitamin D sufficiency.
Thank you, sir. Now, my first, opportunity, I'll go to Bangalore now, where the sun has gone away and, it's been covered by clouds throughout the day. So my friend, Professor Dr. Srinivas Murthy is there. So Srini, over to you for any questions from your audience or for questions from you to the panelists.
Thank you. And it was a great opportunity and great learning from Professor Holick. Thanks for that, sir. It was very illuminating. And as usual, Mangesh is adding icing on the cake to conduct this, and with Bansi sir's crisp lecture. Sir, my first question is what happens to the vitamin D3 in insulin resistance? Because this is the commonest compounding factor we find in most of our diabetics. So especially in the Indian context, so should we give more dose of vitamin D3 compared to the Western patients?
So it's a good question. I mean, there are a lot of studies to suggest that the insulin resistance is less when 25-hydroxyvitamin D concentrations are at least 30 nanograms per ml. And my thinking is that I want all of my patients to be in that range of 40 to 60 nanograms per ml. And I think that can help improve insulin resistance. There is, in my opinion, little evidence that going above 100, for example, like some people have suggested, will make a difference. I don't think so. I think the the body is really happy with a circulating concentration in the range of 30 to 100. And like I said, 40 to 60 is preferred. And if you look at all the literature, it basically is consistent with those observations. And so, yes, vitamin D improvement is good to help decrease insulin resistance.
Okay.
So I think our audience still wants to know what is the dosage recommended for Indians vis-a-vis the Western on the daily dosage or a weekly dosage. We plan to give 60,000 units a week for about 12 weeks. Is it sufficient in the background of insulin resistance, or should we continue beyond 12 weeks, or we have to hike it up to 80 or 1 lakh units per week?
So in my opinion, I don't think that you need to continue the 60,000 units a week, because by then you've filled up your tank. And now if you put them on the 60,000 units every 2 weeks, you will maintain that level. What's really interesting about vitamin D that you're, I'm sure, aware of, is that if you go on 100 units of vitamin D, increase your by 100 units, you go up by 1 and it stays there. If you go on 1,000 units, it goes up by 10 and stays there. You go on 2,000 units, it goes up by 15 to 20 and it stays there. So even though you would have thought that taking more vitamin D, that it would continue to build up in your body, it doesn't do that. And if for some reason the body recognizes the dose that you're on and it maintains that blood level. So for me, as long as your blood level is in that range of 40 to 60, and you will get there if you're taking 60,000 units once a week for 12 weeks, being on every other week, I think will maintain that level and you're perfectly fine. With the exception, of course, is if you're obese. Then you probably need to be on it weekly.
Perfect.
Thank you.
Thank
Thank
you.
you.
Thank you, Srini. Now I fly to our capital city, Delhi. Dr. Gupta, good evening, sir. And I hand it over to you for questions from your center, or you want to ask the question.
Evening, everybody. First of all, I thank API and Elcom for giving me this opportunity to listen to a very relevant topic in our clinical practice every day.
I can
we are
barely
coming
hear
to-
you. Sorry.
You have to speak a little loud, sir.
Yeah, every day we are confused what kind of vitamin D dosage we should be using in our clinical practice and how frequently we should be giving and how long we should be giving. There are certain things which have now become clear that this is a Pandora's box. As the more and more research and more evidence is coming out, we know that vitamin D receptors are present everywhere, and it is effective in preventing most of the diseases and its relevance in reducing insulin resistance and diabetes. Now, there are certain things which are, still comes to my mind, that depending on the levels of vitamin D, whether patient is deficient, insufficient, or sufficient, we now think that 60,000 units per week should be given for 8 to 12 weeks. But how frequently should we check vitamin D levels to see that patient has reached the desired level of 40 nanogram per deciliter? And what should be it continued 60,000 per month and indefinitely without checking, or shall we keep on how frequently checking so that patient doesn't fall into a overdose or a hypervitaminosis?
Nice
Right.
question.
So, yeah, all very good questions. And so basically, for my patients that want to take it daily, I just tell them take 5,000 units a day. Because if you use that calculation of 100 units increasing your blood level by 1, 5,000 units a day gets you between 40 and 60 nanograms per ml. If you want to take it for that 12 weeks, is perfectly fine. What's really interesting also, and it's kind of been suggested and discussed, that if you're severely vitamin D deficient, say you had a 25-hydroxy D of less than 10, do you need to take that much more vitamin D? And the answer turns out to be no. And the reason is that you have several, at least 3 different 25-hydroxylases in your liver. And we showed many years ago that if you're at 10, and if you even go on like 600 units of vitamin D, you will rapidly raise your blood level up to a range of 20 nanograms per ml. But once you get to 20 nanograms per ml, that's when you need 100 units to raise it by 0.6 to 1. And so I never worry about whether the patient's severely deficient or deficient or insufficient. I put them on the same amount. And as you saw in the study that we did, right, we asked the question because I worried a lot of places don't easily have available the 25-hydroxy vitamin D assay, or it's expensive, or in some cases it doesn't work very well. And so we took all comers, right, and I had their blood, but I put them on 50,000 units every week for 8 weeks, and then every 2 weeks forever. And we published that study, and we showed that even those coming in with a 50 nanogram per ml on 50,000 units twice a month, their level only increased to about 70 to 80 nanograms per ml. There was no toxicity. So my recommendation to most of my doctors, and now in the United States with the 2024 guidelines saying you should not screen anyone, is that a lot of the laboratories or the insurance companies are no longer paying for it. And normally a test in the United States costs around $250. So I tell my physician friends, unless they have some major medical issue that is impacting on how vitamin D is being metabolized or utilized, right, is putting them on this dose of vitamin D. You can put them on and not worry at all about toxicity. Right.
That is
The
a-
one,
that is-
yeah, and the one that you've probably seen this, I'm sure, in your practice, because I found it in some of my family members. They're on the same dose of vitamin D as me, right? And yet their blood level is like 20 nanograms higher. And the reason for that is that you have a partial 24-hydroxylase deficiency. Because once you take vitamin D and it's activated in your kidneys, the active form instantly turns on the 24-hydroxylase to destroy it, because otherwise it'd be so toxic. And so there are some people out there that have a partial inability to rapidly destroy it, and as a result, their blood levels will be higher. But again, it does not cause any toxicity and is of no concern.
Yeah, so I think maybe probably the clear message is this, that testing is quite expensive than treating. And maybe probably, the supplementation is more easy, and the recommended dose should be anywhere in the range of around 2,000 to 5,000 units per day, depending on the clinical situation. Is that right, sir?
That's correct. Exactly right. Yeah, it's
Okay.
you can get a whole year's supply of vitamin D for the cost of your assay.
Perfect.
And the assay doesn't give you insight, because you're getting at one point in time. And we
Yes.
showed, by the way, because you may ask the question, so what part of the year should you be taking that test, right? And so
Yeah.
we asked that question in the United States, and we looked at several million blood samples at different latitudes, and we showed that whether you were in the South in Georgia or in Boston, the difference from summer to winter is 9 nanograms per ml. So
Okay.
those that are concerned that, well, but I'm outside a lot and exposed to a lot of sunlight, should I stop taking my vitamin D supplementation? I tell them no, right? Unless you're a lifeguard, right? Or you're a Maasai herder outside every day naked, half naked, you don't have to worry about this.
So now I'll come to Kolkata. My friend, Professor Dr. Udas Ghosh. Over to you, Ghosh, sir, for the question from your center or your question to panelist.
Before going to the question from the audience, I like to ask Dr. Holik, particularly about the high responder versus low responders. Particularly, is it necessary to do the genomic study or other study before going to supplementation of vitamin D, particularly in India?
So in my opinion, so we've done some expression analysis of genes and have done genomics as well. From my perspective, I don't find, even though it looks interesting and they do GWAS kind of studies, is that overall, it doesn't make any difference. And in my opinion, if I give a dose of vitamin D, I get to see a good response, whether they're low responders based on their genetics or high responders. The only way that you are concerned is, and I had developed a vitamin D absorption test many years ago, is that what about patients that you gave vitamin D and you did measure their blood level and it didn't go up, right? And often the cause was celiac disease, right? That they just had a very kind of flat small intestinal mucosa and weren't able to absorb it, right? Patients with fat malabsorption syndromes, it's the same issue, right? Then you have to definitely give them a lot more vitamin D. But for the general population, whether they're high or low responders, in my opinion, I would just give the same amount of vitamin D.
Okay, thank you, sir. Another question is this is the source for the vitamin D is either diet or ultraviolet B rays, but mainly the sunshine. But the peoples are very reluctant to take sunshine in the outside. There is some device, particularly ultraviolet B emitting sources, devices, particularly Soleus. Is it very helpful, particularly those who have a malabsorption syndrome like that? So is it very helpful to provide vitamin D supplementation by these type of device?
So these devices that put out UVB radiation that's responsible for making vitamin D in your skin are very effective, but you have to be super careful because if that device doesn't have some kind of a sensor to check your skin type and the distance, you could wind up getting no vitamin D or getting a severe burn. Because remember, from physics, is that the energy is 1 over distance squared. So fat malabsorption patients, they do benefit. No question about it. We've published this in several places. But the real question that boils down to is the vitamin D that you make from sun exposure any different than when you take it in your diet? And is there any additional benefit of exposure to sunlight because of concern of skin cancer, which is mainly non-melanoma skin cancer? And in my opinion, the answer is we know actually from John Haddad back 40 years ago that when you are exposed to sunlight, you make vitamin D and it slowly enters into your circulation and it gets bound to the vitamin D binding protein. When you take it orally, it instantly gets incorporated into your micelles and chylomicrons, into your lymphatic system, up to the superior vena cava, and then finally to the liver to get converted. 60% is associated with D binding protein. 40% is associated with lipoproteins. The vitamin D associated with lipoproteins has a shorter half-life than it does on D binding protein. And so it's true, when you're exposed to sunlight, the vitamin D level, not 25-hydroxy-D, but the vitamin D level in your blood lasts 2 to 3 times longer than it does when you take it orally.
Mhm.
We also now know from Dr. Slominski's work and our work that when you're exposed to sunlight, that you make other photoproducts. And some of these photoproducts seem to have some powerful biologic functions, including regulating cell growth, potentially decreasing risk for skin cancer. I wrote a review just recently on this, going through all of the mechanisms involved. I mean, Mother Nature is not stupid, right? It's not going to have you be designed to get your major source of vitamin D from sunlight and yet cause you to get cancer, right? And so as a result, what's happening is when you're exposed to sunlight, lots of genes are turned on, protect your DNA. And when you're making vitamin D and photoproducts, it's also helping in that process so that you could take advantage of the beneficial effect of the sun and not worry about the damaging effects.
That is fantastic, I think.
Okay, thank you.
That
So
was
another
wonderful.
question is that particularly you have already mentioned about the immunomodulatory action of vitamin D, and it has some role in autoimmune disease. So what is your opinion about the management of particularly autoimmune disease or rheumatological disease or neurological disease? It is always to do the, I mean, test for the vitamin D level, and you have to co-manage with vitamin D along with the anti-rheumatic drugs or anti drugs for these other neurological disease.
So you may be aware of Dr. Coimbra out of Brazil, who for more than a decade has been giving extremely high doses, 1,000 milligrams per kilogram body weight, to patients with rheumatoid arthritis, psoriasis, etc., and demonstrated that it worked very well. Also, there's a physician in India that went with Dr. Coimbra and used that now in India, and in her practice, she's able to show marked improvement in vitiligo, and in psoriasis, and in other autoimmune disorders. So very high doses of vitamin D is a possibility to be used. I saw a young man who had clear evidence of the beginnings of multiple sclerosis with eye changes and with a clear lesion in his brain. And he came to me and he said that he had heard about the Coimbra protocol. I had been following it for several patients, and that he did not want to be on any kind of medication, but rather wanted to be on high dose vitamin D. So I warned him that, I think it's probably reasonable to be on the MS medication recommended by your neurologist, but he refused, and he wanted only to be on high dose vitamin D, which I did. I put him on 1,000 units per kilogram body weight. It was on like 65,000 units of vitamin D a day. You have to put these patients on very low, zero calcium diet. Otherwise, they will develop hypercalciuria and hypercalcemia. And we published him, and we showed that the lesion in his brain disappeared and
Wow.
that he has no evidence for his multiple sclerosis.
Wow.
Now, what to do for your patients, right? At a minimum, my suggestion for my other patients who are on these medications, right? Because they also impact on your bone health, right? They impact on vitamin D metabolism, is I make sure that they're on between 5 to 10,000 units of vitamin D a day. And I'd like their blood level to be in the range of about 60 to 100 nanograms per ml.
Wow. So thank
Yes,
you
sir.
very much,
Thank you.
Dr. Ghosh, for
Yeah.
this wonderful questions that you're putting. Now I'll come to Pune now, and Professor Dr. Vaishali ma'am is waiting. Vaishali ma'am, over to you for the questions.
Thank you, Dr. Mangesh. And let me start with congratulating Dr. Michael Holick, sir, for that extensive, enlightening talk. I think the questions itself demand a lot of explanation. So he's incited a lot of inquisition amongst the audience here. And I have a lot of questions for him. But before that, I think Dr. Banshi Sabu has done an excellent job of creating this forum for creating social and community awareness. And I think Dr. Mangesh has explicitly covered all the aspects of vitamin D within a short span of time. So I should congratulate you before I start. So nevertheless, I thank the Alchem team for inviting me here today. And there are three questions which are common from all the audience. Is how is vitamin D related to other endocrine disorders? And what happens in hypothyroidism? What happens in infertility? And with PCOS, is there an association with vitamin D and these disorders?
So there are data out there to show that it may be associated with PCOS, and infertility for sure, for both males and females. There's definitely a vitamin D receptor in the ovary. There's definitely a vitamin D receptor in the testes. And so we think that improvement in vitamin D status. That's why I said from inception until death, because infertility is improved by improving vitamin D status. And the third one was what? I'm sorry.
PCOD,
Yeah.
infertility, and hypothyroidism.
Yeah, hyperthyroidism. So
Yeah.
there is evidence. It depends upon the type of hyperthyroidism, right? I mean, you have Hashimoto's thyroiditis and Graves' disease, and there
Yes.
is some evidence to suggest that improving vitamin D status can help in reducing the inflammatory activity for Hashimoto's thyroiditis and even for Graves' disease. And that vitamin D deficiency has been associated with increased risk for both.
So I've seen a lot of benefits in menstrual complaints, especially dysmenorrhea and menorrhagia improving with vitamin D. What is your experience on that? And can you share some light on that?
Yeah, it's the same. I see a lot of young women I'd seen in my clinic, and they had menstrual disorders and discomfort, and improving vitamin D status in some cases made a very big difference. It was very helpful.
Thank you, sir. Thank you for that answer. There's another question from Dr. Rahul, who asks whether there is any foods or drugs which adversely affect the vitamin D levels in the body. Any food interferes with the vitamin D levels or absorption in the body?
Yeah, so it's interesting. I mean, there used to be on the market a product that prevented cholesterol from being absorbed, right? And cholestyramine is another one. It turns out that they will bind vitamin D. And so as a result, you need to take more vitamin D to overcome that. I'm not aware of any foods that prevent you from absorbing vitamin D. And the reason is that vitamin D is incorporated immediately into your micelles and chylomicrons, right? And then it gets incorporated into your lymphatic system, which I had mentioned before. And so fatty foods actually turn out to decrease the bioavailability of vitamin D. And the reason being, and we did a study because I was curious to know in skim milk versus whole milk, right? Is vitamin D more bioavailable in whole milk? Because the thinking was that vitamin D being fat soluble in milk is the reason they put it there because you could absorb it. And it turns out that the more fat that you had, the less vitamin D you absorbed. And the reason being that the vitamin D sticks with the fat and you don't absorb 100% of your fat. And as a result, you lose it. And so, yeah, but I'm not aware of any other foods that really conflict with absorbing vitamin D.
Thank you. Thank you so much, sir. And there's a question by Dr. Rajiv that does vitamin D affect the infection risk, the glycemic status, and the cardiac status in diabetic patients?
I mean, the simple answer is yes. So, I think that our data from COVID and the data from Yale, I mean, clearly demonstrate that you can markedly reduce risk of upper respiratory tract infections. And I think that, the insulin resistance, a lot of data out there to show that vitamin D status makes a difference.
Absolutely. Thank you, Mahika. Thank you, Vaishali.
Thank you so much, and thanks for those questions and those answers. Thank you so much.
Thank you very much, Vaishali ma'am. Now I'll come to Bansi Bhai. If he has any questions, or then I have a question to Bansi Bhai also.
Yes, please. I don't know whether I'm the right. Please.
So, but you spoke beautifully about diabetes and vitamin D relationship. I want to have more specific views on the relation between type 1 diabetes and vitamin D deficiency,
So
especially.
one, that vitamin D has been shown with the immunomodulation, which we have talked about, and there are more autoimmune conditions found to have more in the people who are vitamin D deficiency. But the direct relationship, whether the people with vitamin D deficiency will they develop more type 1 diabetes, that's not been proven. But yes, definitely vitamin D deficiency in a person with type 1 diabetes will make them more prone to have more problems related to other metabolic problems. So definitely a persons with any sort of conditions, particularly like type 1 diabetes and type 2 diabetes, we as a diabetologist or endocrinologist would like to keep their vitamin D level in a sufficient level, but now more with a desirable level, which is between 40 to 60 milligram. And as I practice very regularly to all my patients, to give them a maintenance dose, which is very, very important. I write it very clearly on my prescription that this should be taken once in a month, lifelong. So that is what we do. But yes, still there is non-compliant people. They don't take it regularly. And I think I don't say that people are non-compliant. We as a doctors are not teaching or educating the patients properly. Otherwise, it's not very, very cost effective. And if we teach the patient properly, most of them would like to continue it lifelong.
Okay, thank you, Bansi. And in fact, interestingly, there have been a couple of studies which have shown that the babies born to mothers where really you have little lesser sunshine and very high wintry times, where less sunshine is available, the incidence of type 1 diabetes in these kids are very high. And even, after the developmental age also, the metabolic challenges in these kids, they are very high in
Yes, metabolic
comparison to the
challenges are
kids.
definitely high,
Yes.
but yes, the type 1 diabetes, which you had said very rightly.
Yes, absolutely. Now,
Dr.
last,
Michael, my question is that
yes.
American Diabetic Association suddenly is saying that vitamin D level is not to be measured. It is not required. Why so? With so much evidence which is there already. And so many other international guidelines are strongly saying that it should be measured. Why they are saying that it's no more required? I mean, is it like that everyone you give them supplementation or you did not to be measured for that? What is the reason?
So like I said, I mean, in the United States now, a lot of companies, a lot of the reference labs are no longer going to be paying for that assay because the 2024 guidelines said you should never screen. And they didn't include obesity in their consideration at all, or patients on glucocorticoids, right? Or patients with sarcoidosis, right? And so there's a lot of reasons to be evaluating certain groups of patients. But I think in general, you can assume that your patient's vitamin D deficient, right? Unless, like I said, they're lifeguards, right? Or hunter-gatherers. And so as a result, putting them on appropriate supplementation should be fine. And I think it's a cost-effective way of being able to do that. And like I said, we did the studies. We published for 6 years demonstrating that they all raise their blood level in that preferred range of 40 to 60 nanograms per ml on equivalent of about 3,000 to 4,000 units of vitamin D a day, or 60,000 units, for example, twice a month.
In fact,
And the testing in vitamin D in US is very costly because in India, testing vitamin D level is around $10 in the
Yes.
private labs.
Yes,
While if you test the lab in US, will it be very costly?
he said $250.
About $250 for a test.
Too
Yeah.
much.
Yeah, so in fact, what I take from his, maybe probably my analysis, Banshi Bhai, if you allow me, is this that there may not be a very clear establishment of a causal relationship with various challenges, but therapeutic relationships and outcome benefits are far more established in vitamin D treatment and the other related challenges rather than the causal challenge. So that could be one reason. And the second thing is that it is too expensive for testing, especially in the United States. So that could be one of the reasons why they are now saying that don't test, just treat. So that could be the
Right.
hidden message that they are trying to give, maybe probably.
That is what.
Yep.
So the final question from me, and then I'll quickly come to our panelists to have their final comments before we wind up this program. And this is a holy grail question to Professor Hollick, sir. Why in India, despite of having so much of adequate sunshine, why we develop vitamin D deficiency so significant?
So there's a couple of reasons. The obvious one is, right, and it's curious human nature, right? Very light-skinned white people go to tanning beds to get tan. People who are tan or dark-skinned don't want to get darker, right? And so as a result, just culturally, right, you're not going to have people go out in the sun because you are going to increase your skin pigment. That's a guarantee. So they avoid that, right? And heavily promoting sunscreen use, right? A sunscreen, by the way, with an SPF of 30 applied properly, 2 milligrams per centimeter squared, decreases vitamin D production by 97 to 98%. The betel nut that you probably are aware of is, it can be popular for chewing. It induces the 24-hydroxylase and actually makes you more vitamin D deficient. And so there are certain, habits and cultural issues that really put the Indian population at very high risk for vitamin D deficiency, even though you have plentiful sun.
Yeah. Thank you. Thank you for that beautiful answer, sir. Now I'll come to Srini for your final comment, your one take-home message for everybody.
I think as the AD has clearly told us not to measure it and treat it, and treat all our diabetic patients and comorbidities, never miss and don't bother to check. That's the take-home message from my side, that you need to treat them continuously and maintain a level of about 20 nanograms per ml. I think that's something which is very important in our diabetics. And like in US, I think the cost and the price of the test and the price of the tablet also, there is a huge discrimination in India as well. So though it is only $10 for an US person, but in India it's $1,000. So it's really huge as far as Indians are concerned for testing. So go ahead and no second thought of not treating anybody for vitamin D deficiency.
Thank you, Srini. It was wonderful having you. Dr. Gupta.
Yeah, I think we have now quite clear about the dosage and how long we need to give it and how frequently we need to check it. One quick question from Dr. Holick. As we treat a lot of diabetics with this dose of 60,000 units per month, we know the diabetes comes with a CKD and the progressive decline of renal functions. This is not metabolized into an active form, and we keep giving it every month. Are there any guidelines when we should shift it to a active form of calcitriol or alpha calcidol or any EGFR where it should be stopped and we should shift, or what are the guidelines regarding that?
Yeah. So first of all, I think 60,000 twice a month rather than once a month is better. The National Kidney Foundation and the International Kidney Foundation all recommend that CKD patients should maintain a blood level of 25-hydroxyvitamin D of at least 30 nanograms per ml. Typically, so there are two things going on in CKD that often is not appreciated. So even in stage 2, 3, if you don't clear phosphate well and your phosphate level starts to go up, your FGF23 goes up, it then decreases the renal production of 125D. So the most important in early renal failure is to maintain your phosphate in the normal range, because then you have enough 1-hydroxylase activity to make active vitamin D. But typically, if the GFR is less than 30, we know from a lot of studies that they definitely need replacement with either 1-alpha-hydroxyvitamin D, 125D calcitriol, or one of the analogs that's available.
Thank you. Thank you very much, sir.
Now to Dr. Ghosh.
Yeah. My message is more or less same tune. Don't jump for the vitamin D testing. It is necessary because it has been seen from the holics. I mean, these the neurological, rheumatological, cardiovascular, and on all the systems involved with the vitamin D deficiency resulting in the poor prognosis. So no need to test this vitamin D, give a supplement of that. About the injectable therapy, there is no role of the injectable therapy of vitamin D. Rather, is the oral preparation is much better. And nano formulation, though it is a good absorption and good viability, but very much costly. No need to do these things. Give oral formulation of vitamin D, and that will be for the 8 weeks. If you don't test it, do give for the 8 weeks. 60,000 weekly for the 8 weeks. That is my message.
Thank you, Dr. Ghosh. Dr. Vaishali, ma'am.
Yeah, so I think from today's symposium, it's clear that vitamin D is no longer only a vitamin. It's a hormone which has a multi-system effect. It is acting on different organs in different comorbidities. There is a high prevalence, not only elsewhere, but in India too, wherever we have good sunlight. And there is a high prevalence of deficiency, secondary hyperpara, tertiary hyperpara related to vitamin D deficiency. Even in India, we are seeing it today very rampantly. And I think vitamin D treatment is highly rewarding and it's a necessity as far as our NCD patients. I'm not talking only of diabetes, it's obesity, metabolic syndrome, hypertension, cardiac disease, and a lot of diseases which Dr. Hollick enlisted. And I'm so thankful that Dr. Hollick has given his whole life dedicated to the work of this vitamin D and he shared his experience with us today so that we can be enlightened. Thank you so much.
Thank you. Banshi bhai, your message. Bansi, you have to unmute yourself for your message.
I mean, finally, what I can say, there was a lot of learning, a lot of sharing the knowledge. We could get so many people on one platform, so many experts from all over India. But I see always that to listen, Dr. Michael, again and again, we have listened in past also. It's very enlightening, and I'm sure I just suggested, Mangesh, I was writing to you that we should write a press also, a media also. We should release a press note
110%.
tomorrow on
Yes.
this vitamin D, as today we have discussed with Dr. Michael Hollick, and I think that will go to the lay people, that
Yes.
they should also understand the importance of vitamin D issue, because the awareness is the only key by which we can improve the vitamin D status in our country. So
Yes.
my humble suggestion to you, with IGCP and with the support of ALCAM, from you, from API, we can release a press release, and that it can be widely circulated. And we have all over India, you have already experts who have involved as a panelist. They also can circulate the same press release in the local media. So I'm sure across the country we will able to, give this message to lay people also. And I'm sure tomorrow, my great friend, close friend, Srinivas Murthy is going to put something on social media. So we, all of us can repost it again and again.
Yes.
So that will also circulate the things. So
Fantastic.
some of you who are very, very, very active in social media posting, please do it. So we all can repost it, and it will also go to thousands of people.
Wow.
Thank you. Thank you.
I'm
Good
so happy to say, Dr. Hollick and Banshi bhai and all the panelists, and we have more than 10,000 registrations today. That was
Wow.
outstanding activity. And absolutely, they were all, I am more than sure about it, they were all enlightened. There have been so many misconceptions which were taken care of. The masterly oration, not only from Dr. Hollick, but Bansi bhai, really changed the whole way, the perspective of vitamin. And of course, my fellow panelists, Dr. Srinivas Murthy, Dr. Vipul Gupta, Dr. Udas Ghosh, Dr. Vaishali Deshmukh, really have changed the way the whole program has went on. And of course, entire Alkem team, IGCP team, and our tech team for this wonderful, wonderful opportunity which has been bestowed on us. So over to you, Dr. Vijaya, or anybody from Alkem, for the final words and thanks. And then, of course, I wish all the participants without whom we all would not have been so happy. And we love you, we respect you, because it was Banshi bhai who has told me that always respect time of the people, those who really love you. Always respect that, because that tells you how much they love you. So thank you very much for spending your working evening times with us. And I believe that Dr. Hollick, with his masterly presentation, along with Dr. Banshi, Dr. Vaishali, Dr. Srinivas, and of course, Dr. Gupta and Dr. Udas, have definitely given us some pearls of wisdom as far as vitamin D is concerned. Over to you, Dr. Vijaya, for the final comments before we wind off.
Thank you, sir. So as we conclude this enlightening session, on behalf of Alkem Laboratories, we would like to extend our heartfelt gratitude to Dr. Michael Hollick, sir, for sharing his invaluable perspectives backed by decades of groundbreaking research and clinical excellence with us. We are also very grateful to Dr. Banshi Sabu sir for providing an excellent and detailed explanation of role of vitamin D in diabetes, especially in precisely timed manner. Also, a special appreciation goes to our moderator, Dr. Mangesh Tivaskar sir, and panelist, Dr. Vaishali Deshmukh ma'am, Dr. Uday Chandra Ghosh sir, Dr. Vipul Gupta sir, and Dr. Srinivas Murthy sir for moderating the session so seamlessly and ensuring a lively and interactive discussion at each center. We are delighted to share that over 10,000 doctors have registered for this conclave and more than 1,200 delegates have attended this program live across the India. Also, over 200 doctors have watched this program over the centers pan-India. A big thank you to all the attendees. We hope you found this session insightful and enriching. Our deep gratitude also goes to Association of Physicians of India for extending their support to make this event possible. And many thanks to our event and scientific partner, IJCP. So thank you all once again and wishing you all a wonderful weekend. Goodbye.
Thank you.
Thank you very much. Good night, everybody.
Night.
And a
Thank you
very
and good
good
night.
morning.
Yeah.